Good afternoon, and I thank Sandeep and team and entire scientific committee of EURA to give me an opportunity to present topic on chronic pain, which is I'm talking on neck pain. So, how many of you are practicing chronic pain in your practice? Maybe 10%, 15%. Few hands here, there, okay. And how many of you are planning to practice chronic pain in your practice, maybe part-time, full-time or whatever? How many are in intention of practicing, friend? Okay, good. So, I think as the number of hands I've seen, the interest in chronic pain is increasing. Anesthesiologists are leaders in managing chronic pain. And most of the pain which comes to our clinic is spine pain, cancer pain, apart from neuropathic pain. These are the three major components of pain which are troublesome to the patients. So I'm talking mainly on neck pain today. I'll give you a number of things which we can do for neck pain. Before that, people who want to learn chronic pain and who have some intention of practicing chronic pain in their practice, they can go to our website ISSPCon 2014, which is a national conference which is to be held in New Mumbai at D.Y. Patil Medical College. Registrations are open, and this will be one of the best conference on chronic pain. I think you should not miss it if you are really interested in learning it. So with that, before you have a patient coming to your clinic, you should know what are the things you should do in history, in clinical examination, and then what are the different things as an interventional pain management specialist you have in your armamentarium. So history is very important, and you have to listen to the patient, do not interrupt. And more than 50% of the patients you can diagnose just on history. As we know from our medical knowledge and our education that past medical history, surgical history and social history are important when you are understanding patient's pain. All the important things we know. I'm not going to waste my time on this, but onset, how the patient's pain developed, is there any history of trauma, what are the things which improve the pain, what are the things which reduces the pain. All these factors has to be asked before you go for diagnosis. After vital and systemic examination, you have to see neurological examination, because neck consists of a major cervical, is a spinal cord starts from there, and you have to see general mental status, cranial nerves involvement, motor and sensory nerves which are involved in the upper limb and or the shoulder area, what are the reflexes in the upper limb. All this general examination you should know how to analyze those things. I'm not going into details of that. And dermatomes, which are very important, you should know your dermatome very well. As an anesthesiologist, I am sure most of the people, they know their dermatome, what is the area of hand. So I'm just going into some important nerves. So this is C4. You have neck and shoulder, deltoid occipital area, which are the area where the pain radiates. Deltoid is the motor component which is depressed if C4 is compressed by a slip disc or any other problem. And this is the deltoid area which is having sensory deficit. C5 is shoulder and bicep. Motor changes are seen in deltoid, supraspinatus, infraspinatus, and upper lateral shoulder and upper biceps. Reflexes which are depressed are biceps. C6, again shoulder, lateral aspect of the forearm, thumb and index finger. So you have C4, you have C5 and you have C6. C7 is a middle one, C8 goes here, T1. So this is a common thing what we see, even when we are doing a brachial plexus block. So what are the tests we do when patient comes to us with neck pain? We do X-rays, we do CT scan, MRIs, sometimes CT myelogram and bone scan to be done in specific conditions. These give specific information, and this is a C3 body. If you see C2, it is a On lateral X-ray, see to the facet process is the largest one. From here we start counting. See 3, 4, 5, 6, 7 and T1 where the rib is attached. And if you see here a AP, you have a rib attached to T1 vertebrae. So you can even count from down. See 7, 6, 5, 4, 3 and 2 will be up. So understanding radiology is also a very important part of understanding and practicing chronic pain management. And then this is a little oblique view where you can see a status of foramen, and if the alignment of the vertebrae, if there is a listhesis where the bones are anterior, there is a movement of bones anterior posteriorly, the foramen may be causing compression of the nerve root. And this is a open mouth view of C1, C2 joint where you can see atlantoaxial joint here. So there might be some arthritis which can cause neck pain and a pain going down, going in the head. So cervicogenic headache is one entity which we treat in our chronic pain management clinic. So you have this patient which has pain going in the arm. It should be, these are the patient, they have a multiple level of disc. This is very common presentation in our clinic and they come with a cervical radicular pain. Previously we used to do something called a transforaminal epidural injection in the cervical area, which Kritika has shown a good slide where you inject in the foramen in the lumbar area. But in cervical area we don't do any more because there are major arteries which are supplying directly to the spinal cord, and if you put your needle there and artery goes in spasm or you inject a steroid in the artery, it can cause ischemia of the spinal cord and it can be very dangerous. So world over, the transforaminal route for in cervical area is been almost abolished. Not many people are doing it. There are very specific indications where transforaminal injection in cervical area is being done, and they are very limited. Like some surgeon want to know what nerve is causing pain, so we go selectively over that area. Selectively that nerve is given local anesthetic with all the consent about the risk factors taken beforehand. So apart from MRI, we also sometimes do EMG and NCV, nerve conduction velocity test, to rule out certain condition which can cause pain which is mimicking the radicular pain. Most common condition is carpal tunnel syndrome, shoulder hand syndrome. They can present like a radicular pain with tingling, numbness, heaviness, burning. So you are sometimes really confused whether it is a cervical area which is giving pain or is it something else which is causing pain. So we do EMG, which helps in establishing diagnosis. But standalone EMG or NCV cannot give you diagnosis. You should not over rely on this test. So there are lots of things which can happen in the neck, right from degenerative, neoplastic, inflammatory and traumatic, apart from infection. Infection, when I say tuberculosis, is one of the very major concern in our country. And if you have somebody with radicular pain, evening rise of temperature or a history of weight loss, you have to rule out some pus collection or some signs of tuberculosis in neck area. Neoplasm itself, in aged people, patient who are more than 60, you have to be having higher index of your suspicion, highest index of suspicion that patient might be having upper cervical, some metastatic lesion, or patient is having some epidural abscess, or patient is having some tubercular abscess. And these are seen very, in a year I see at least 3 to 4 patients who come as cervical radicular pain, and they have done X-ray showing nothing, and on MRI we see all these patients, all these things. So this is one patient who has radicular pain with some injury, and it is going sharp shooting, stabbing, knife-like pain in the neck, and is going to right shoulder and right arm. So these are patients with acute radicular pain, and these patients can be very well managed with conservative line of management. But if they are not improving with medicines and physiotherapy and they are still having pain, we have a very good treatment called cervical epidural injection, and this is simple C-arm guided procedure. Patient in prone position, you give a local anesthesia, a routine epidural what we perform, same thing is performed, but it is in the live C-arm guidance. You need to direct your needle to right or left, and normally I use hanging drop method in this to identify the epidural space. So I'll just show the picture later. So hanging drop, once it is going inside, the drop will be sucked in. So every millimeter is important. Try to have a tactile sensation. You can feel the loss of resistance at every ligament you cross, every tissue you cross. And always try to adjust your tip when you are looking in the C-arm, whether it is going lateral, medial, you want to be in midline or little bit away from the midline. If patient is having only one side pain, we inject entire drug on that side. Okay, so this is beautiful, and it is going on one side where the patient's pain is there. So we inject a dye. It is not seen clearly, but you can see a dye spread here, and we inject around 5 cc of the tricot, which is triamcinolone, along with 1 cc of local anesthetic, which is 0.25% sensoricin, diluted in normal saline. So this is the picture where you have a unilateral spread of the dye, and if you inject, after injecting dye, you inject your local anesthetic, the drug, which goes only in the area where it is required. Sometimes you have a upper cervical disc prolapse, you put a catheter up to this area, you inject dye, you see the dye spread, and then you inject at the level where it is required. If it is only single level, you don't have to inject 5 cc, you can inject just 2 cc or 3 cc. You have to adjust the volume accordingly. So second case, very commonly found pain in the posterior neck, both shoulder, upper extremity, and started several years ago. Slowly is getting worse. So it is not radiating anywhere, it is localized. Many patients, there is a pain, it is on and off. Patient takes some treatment, again it comes back, sometimes become very severe. So these are the chronic sufferers. With some treatment they get better. These are the patients who are suffering from facet joint pain. On palpation of the lateral part of the neck, you can actually feel a lot of tenderness. And if you give a medial branch block, so this is the body of vertebra. If you go from here, this is the facetal process. You put your needle here under X-ray control, inject half cc of local anesthetic at 2 or 3 levels, and you see dramatic relief. Immediately patient feel free neck, he can move his neck, range of motion improves, whatever referred pain in the shoulder or in the upper back, it goes away, and you can apply a radiofrequency ablation, which is a radiofrequency current applied through a needle over the nerve, and you can burn that nerve, the medial branch. It is not a main nerve, but it is a branch of the main nerve which supply the facet joint. You burn that nerve. Usually patients have relief anywhere between 9 months to 18 months, sometime more than that. So this is a typical operative room picture where you have C-arm, the ITV, and you are doing the radiofrequency treatment. Another common thing, you have cancer patients having sudden onset of neck pain. What do you suggest? You have high index of suspicion for metastasis. So these are the patients, you have to do investigation, see the extent of metastasis, and treat it accordingly with opioid. Sometimes we give epidural injection in these cases where you can reduce, if there is an epidural extension which is compressing the cord, epidural steroid injection helps them, local radiation, chemotherapy, everything helps. So you have to guide the patient accordingly, and morphine is a mainstay of treatment in patient with generalized metastatic pain. So another patient we come across is trauma due to vehicular accident. So they start getting, suppose this patient falls down from motorcycle, started severe pain in the arm. So you have something called whiplash injury. There are a lot of differential diagnosis when you are dealing with neck pain. So these are common things. We have to know our anatomy, our pathology, our medicine knowledge, and some orthopedic knowledge when you are dealing with neck pain. So this is a typical patient, cervicogenic headache. I told you this is a AA joint. On MRI you can see arthritis of AA joint. Patient on movement on that side, he start getting pain which goes in the head, very severe pain. He cannot concentrate on his work. So we can do a joint block. A simple steroid injection can give rise to very long-term pain relief. You can do radio frequency treatment for that area. You can you can put a radio frequency needle and apply a pulse radio frequency current. Then Kritika told about complex regional pain syndrome or post-surgery pain, causalgia, which can be treated with stellate ganglion block. So this is a stellate ganglion block. So you have to put your needle at C6 or C7. Yeah. And the last one is spinal cord stimulator, which is a treatment for choice of neuropathic pain. So this is the leads, is a pacemaker in the spine. So just few pictures and I'm just finishing. So thank you, and we look forward to see you at ISSB Con. Thank you very much.